So hello, everybody, and thank you very much for the invitation. I'm very honored to be here, and I see some very good friends. I hope you can see my screen now.
Yes, we can.
Okay. I was asked to speak about flow diversion, and I start with my disclaimer. Of course, I have some conflict of interest. The major one is that I have a big bias in favor of flow diverters. So you will understand and see it during my presentation. I really believe that flow diverters have been a major revolution in the treatment of intracranial aneurysms. The first one was coiling, and then a few years later we had flow diversion. Why? Because they allow to treat in a simpler way aneurysms which are very difficult to treat in different ways. Two, they allow the treatment of impossible to treat aneurysms, but mainly three, they make aneurysm de facto disappear, which means that there is a permanent cure. As you have seen before, the endovascular treatment has always been criticized because there are many recanalizations, not with flow diverters. So I will just show you examples to show this. Treat in a simpler way, aneurysm very difficult to treat. I could choose between hundreds of cases. I just show you a few of them. So this is a 66-year-old lady, and incidentally, she discovered to have this aneurysm, and this is the CTA on the pica artery. Angiography shows a large, round, spheric aneurysm on the pica. So as what could we do here? Well, of course, surgery has an option. You could do direct clipping or end-to-end anastomosis or bypass. Not easy. We could stent and coil with success or not much, but if you have to stent, you can well use the flow diverter. And this is what we did. You can see here the deployment of the flow diverter inside the pica artery across the neck of the aneurysm. This is the end of the procedure, and the 6 months follow-up shows the complete disappearance of the aneurysm in a case which was not so easy to be treated. And there are, of course, no ischemic lesions in the cerebellum. A different case, an 11-year-old kid who had an MCA aneurysm, fusiform, growing over years. And this is the M1, M2 aneurysm. What could we do? Well, we could do, of course, bypass surgery, but easier a flow diverter. And the 2-year follow-up shows that the aneurysm has gone, and you can see the shrinking of the aneurysm over the 2 years period. Another case, this is a subarachnoid hemorrhage, a blood blister-like aneurysm in a 65-year-old lady. You see the hemorrhage there. And there is this strange-looking pseudoaneurysm on the side of the carotid artery. What could you do here? Maybe surgical wrapping. We know that sometimes it doesn't work. But with the flow diverter, you exclude the aneurysm, and also you reinforce the artery itself, which is usually the reason for the aneurysm itself. And here again, no lesions on the MR scan. If you have an acute subdural falx hematoma due to this dissecting aneurysm of a branch of the pericallosal artery, what could you do? The only thing you could do probably would be to occlude the artery. Can you do better? Well, we place the flow diverter on the origin of the artery, and at the 6 months follow-up, this was before, the aneurysm has completely disappeared, and the artery is still there. So no occlusion of the artery, still working, but complete disappearance of the pseudoaneurysm. This is something that you cannot get in any other way. How about this wide, large neck, extremely large neck aneurysma. Somebody put some coils in there without obviously any real success. And you can see how big and long is the neck in this aneurysma. What could you do here? Well, we placed the flow diverter, and again, at 6 months, everything had disappeared before, and at 6 months, it shows the normalization of the artery there. The second point was the flow diverters allow the treatment of impossible to treat aneurysms. What does that mean? Well, look at this aneurysm. This is a dissecting aneurysm of the posterior cerebral artery. And geographically, it's a fusiform, long, elongated aneurysm, which includes the bifurcation of the posterior cerebral artery there. What can you do here? Well, placing a flow diverter, really. And at 6 months, the lesion has completely disappeared, and geographically, it's no more there. And the bifurcation is still there. The two branches are still there. More important is if you look at the MR, the big ball has completely shrunk. There is no more compression on the brainstem. So it's really the disappearance of the lesion. Again, in this case, a large fusiform giant aneurysm that compresses the medulla there and gives lower cranial nerves. It's partially thrombosed. There is no way to treat this aneurysm unless you want to occlude the vertebral artery, but the pica comes off from there. If you look at it, the 6 months follow-up, the pica is still there. The aneurysm has completely shrunk, as you can see from at the MR. And the medulla has regained its normal status. Fusiform aneurysm of the paraclinoid segment of the internal carotid artery with the ophthalmic artery coming off from the aneurysm. It looks like really an impossible aneurysm to treat. You place a flow diverter here, and at 6 months, the aneurysm has disappeared. It was like this before. It's like this at 6 months, and the ophthalmic artery is perfectly seen also here. Another strange case with the perforators that come off the tip or the top of this aneurysm. And if you place a flow diverter, at 1 year, the perforators now are completely separated from the remaining smaller sac of the aneurysm, also in the lateral view. This is a very big, giant aneurysm in a young girl with hypophyseal problems. Look at this. How can you treat something like this? Of course, you could occlude the internal carotid artery. This is the giant aneurysm of the cavernous and petrous portion of the eye. But the collaterals are not so good. A1 on the other side is very small. The posterior communicating artery is not enough. You could do, of course, a bypass surgery or place a long segment and train of flow diverters. The symptoms go away quite quickly. And at 18 months, you can see the results of this treatment. The internal carotid artery is there, and especially the aneurysm is completely shrunk, is no more there, and only the artery is there. And finally, this example of a young man who had an Ehlers-Danlos disease, and he had a pseudoaneurysm where we had treated a carotid cavernous fistula 20 years before. And look at what happened. There is this incredible mass growing inside his head. This is just thrombotic vascular aneurysm, which we treated with flow diverters in the petrous bone. And the shrinking of this mass is very well visible over 3 years, it went away with the resolution of the symptoms. And finally, the third point is that flow diverters make aneurysms de facto disappear. So we will play a little game, which is called Where Was the Aneurysm? I show you an image and I tell you where was the aneurysm that we treated with a flow diverter. Why this? Because if you look at this, it looks like a perfectly normal artery. And it's very difficult to say, well, there was an aneurysm. Yes, where? Here. And this is a giant aneurysm of the intracavernous. And you can see how 6 months later, it's the image shows you a perfectly normal artery. And also, especially, the aneurysm has shrunk to nothing. So the aneurysm has disappeared. And in this case, where was the aneurysm? Again, you see just a normal arterial image. And if you think that there was an aneurysm before, well, it was difficult to say where it was because everything is normal now. And this was the aneurysm before. At 1 year, the aneurysm has shrunk and is fibrotic. So it's a scar, it's a dead aneurysm. It will never recanalize. Again, where was the aneurysm? If you look at these images, difficult to say. Everything looks normal, but finally the aneurysm was there. Again, a pica origin aneurysm, and very interestingly, at 6 months, the pica is absolutely present, as you can see here, but the aneurysm has gone. And again, at the MR, it was not visible anymore. Here, where was the aneurysm? It was there, and difficult to say just looking at the images. Here, everything looks normal, but before there was an aneurysm there, a dissecting aneurysm in a young girl, which was treated just by placing a flow diverter. Here, very nice looking normal artery. There was an aneurysm there. And finally here, there was a subarachnoid hemorrhage. And where was the aneurysm before? Difficult to say, but that was the aneurysm that caused the subarachnoid hemorrhage. And in this case, we just placed a flow diverter in the vertebral artery, not in the pica, just by changing the flow inside the aneurysm, which means by remodulating the flow, the aneurysm disappeared. So just to answer briefly to the questions that were given to me, the indications are, well, all aneurysm, not accessible to simple coiling, or where you think that the coiling will not be successful. Of course, these are mostly wide neck aneurysm larger than 10 millimeters. Sidewall dissecting fusiform, sorry. Especially incidental, they could be also symptomatic or ruptured aneurysm. We have treated many subarachnoid hemorrhage ruptured aneurysm dissecting usually with flow diverters. They could be even small vessels, distal location, bifurcations, anywhere. But I want to stress the fact that we don't treat small incidental aneurysm because we think that they should not be treated. The challenges are usually the access with microcatheters because especially in giant aneurysms, it's difficult to go beyond the aneurysm. Finally, the catheterization needs some expertise. The deployment could be not easy in some cases because the device will not open immediately or perfectly and not in the right position. You just have to work on it. The correct wall position also, it's something that you have to learn how to obtain it. Some people use balloons, we don't like it. When you have to place multiple devices, one inside the other could be a little bit difficult, but usually it's not a problem. And of course, the big problem is dual antiplatelets because these patients have to be treated for some times with antiplatelet therapy. And finally, the limitations we think are the crossroad aneurysms. What is the crossroad? Usually the top of the basilar is not a good position to be treated with
with flow diverter, and also at the level of the posterior communicating artery, where it comes from the sides where the posterior flow comes in. And of course, the dolicho-basilar artery atherosclerotic dilatations, where nothing works, we think, so far. So finally, the conclusion are that flow diverters are certainly a revolution. We can treat aneurysm once impossible to treat, and aneurysms disappear. What is more curative than the disappearance of the disease? Thank you very much.